Welcome to the Catalyst Podcast. I'm your host, Charles Epstein. Joining me today is Dr. Timothy McBride, currently the Bernard Becker Professor in the School of Public Health at Washington University in St. Louis. Dr. McBride, who received his PhD in economics from the University of Wisconsin, focuses his research in the areas of health economics, health policy, and aging. In particular, most of his research focuses on Medicare policy, health reform, the uninsured, and insurance markets, rural health, Medicaid, and long-term care. Tim is co-author or editor of 2 books, several book chapters, and several dozen journal articles in these subject areas. Tim, hey, welcome.
Hey, thanks for inviting me. I'm looking forward to this because we actually have, as you can tell, wide-ranging discussions. So
Absolutely. And I prepared about 10 questions. It could have been 20 questions. So, it's kind of interesting because our conversation in the lead up to this, to prepare for this, I said to you, you know what? I should just edit this and use this as our pod because it was so wide ranging
yeah,
and such a fascinating conversation. But in any case, so I really do appreciate you taking time to spend with me today. First question right out of the gate, you received your PhD, as I mentioned, in economics, but what made you want to focus on health economics and health policy? Why did you want to make those your primary areas of focus?
yeah, it's an interesting question because I was trained as an economist, and I still think of myself as an economist, and went to a storied program, University of Wisconsin-Madison, that does a lot of work on public policy. But when I went into economics, always had a policy focus, and I started off at the Urban Institute, and I was working on, you know, public policy, mostly in aging and Social Security. But I very quickly got affiliated with the People in Health Policy at the Urban Institute, and it's one of the best health policy groups in the country. I think, frankly, maybe the best in terms of numbers and of people. And so once I started to work on the uninsured and long-term care, I was hooked. And then when I moved to academia, people saw me as a health economist and a health policy person. And so that's been pretty much the path my career has taken since then, and it's been fine with me because health economics is a really important branch of economics. And it's interesting, my mentor, the great Robert Lampman from Wisconsin, I remember he told me at one point, he said, "Well, don't do health economics because that's not really economics." And we can talk about why he said that, but and I think we will because I think it's in part in your questions. But I think, frankly, I would say that I like all of economics, but I find the health markets the part of economics that's the most fascinating.
Well, which tees up the next question, of course. And by the way, if you're going to be stereotyped, might as well be stereotypes the health economist. It is
Yeah,
a pretty fascinating and deeply relevant, particularly right now,
right.
field. In your view, what's the biggest misconception politicians, people generally have about healthcare economics?
Well, I think it's not those of us in health economics don't have this misconception, but you're right, politicians and policymakers, maybe the general public does. When they think of health economics, they think of health markets as working, that there's a free market that works in healthcare. Those of us in health economics know that's not the case. As I like to say to people, I think a lot of politicians have an Econ 101 view of health markets, but it's really an intermediate or an advanced knowledge that you need to understand what we call market failures. So I think health markets are interesting because they're very complicated and they are characterized by a lot of things that violate the assumptions of free market principles. But that's why my major professor said, "Well, you don't want to study health economics because it's not really a market." I disagree with him actually, because I think it is a market. There are market principles that are come into play, such as demand and supply and incentives and a whole bunch of things. But there's a whole bunch of market failures, which if you don't pay attention to those, then you make a lot of policy mistakes. And that's why I think it's pretty interesting to dive into health economics.
And again, we touched on this a little bit in our pre-production call, and I think it kind of goes to my next question. about the Affordable Care Act, which created
Right.
an Amazon-like marketplace for insurance. But it's kind of an imperfect marketplace, right? Because in a marketplace, you fundamentally need the ability to comparison shop, and you really can't do that. And would you consider that one of the fundamental reasons why it's not a classic marketplace, or in your words, it's a flawed marketplace?
Well, and I think when the Affordable Care Act was created to create that ACA marketplace, sometimes called Obamacare, which is, the piece of the private marketplace where people can go, don't have other sources of coverage above the poverty line. It's actually a great example of what we're talking about, like you mentioned, is it was well understood by health policy people and health economists that you you needed to create this marketplace. But if you think about it, why would we need to do that? We don't go out and create a marketplace to sell computers or create a marketplace to sell groceries. It just sort of happens. That's the point of economics. That's what Adam Smith
Mm.
taught us. It just sort of it creates itself. Amazon created itself. But what's great about Amazon is that you can go up to one place, click on it, type it in their server, and voila, you get a whole bunch of choices. And then you can navigate all that, and you can look at ratings, and you can look at prices, and so on. And so the thought of the ACA marketplaces was we need something like that for insurance, or an Expedia for health insurance, where you can basically price compare health insurance. But that wasn't being created by the so-called market, the free market. So the government kind of had to go in and create that. But furthermore, the other main point is that it had to regulate it, because even if it got created like an Amazon type or an Expedia type thing, it would be unregulated and sort of out of control. And that was what characterized our insurance market until the Obamacare came into place, because you need to put some parameters around it so that it doesn't, you have to protect the consumers and the providers in the system. And that's the whole point of the marketplace and some of the other things that were put in recent reforms.
Yeah, I think people tend to conflate healthcare with the marketplace, much like a lot of people tend to conflate the economy with the stock market.
Yeah,
They are not necessarily one and the same. Healthcare, as far as talking about the Affordable Care Act and this so-called marketplace, yeah, you're shopping for insurance, which is a
right.
very, very difficult thing. And would be kind of interesting. You mentioned Amazon. Now they have that Rufus AI tool, which is really powerful. It's really great. So you can find something and ask it questions, and you can really drill down to find what exactly matches your parameters. So it minimizes the buyer's remorse you may have. But there's also obviously a lack of transparency when you get down to the actual healthcare products.
Right.
Right? I mean, I can't
It,
necessarily compare. I mean, if I need a procedure, how do I go about price shopping, or how do I go about comparison shopping? I don't have that
yeah,
expertise. I don't even have that kind of transparency into pricing.
that's one of the biggest, we had mentioned earlier that there's big so-called market failures or deviations of health markets from other marketplaces. So as you're just pointed out, you can go on to many other markets. Like if you walk down the grocery store, you can just walk down the aisle. It's got all the prices, it's got all the weights, and you can look on the actual thing, and it lists all the nutrition stuff. There's flaws in it, but you know what's in and lists all the ingredients.
Right.
But do we have something like that for healthcare? No. And so if you're trying to choose between a hospital or procedure or a doctor or a healthcare system, how the heck do people do that? And it's so complicated because healthcare is complicated. So and so just to cite another example, there's a friend of mine, and frankly, the Trump administration's been very big on this, and I applaud them for it on creating medical price transparency. And
Mhm.
they didn't start this. This was started under the Biden and Obama administrations. But be that as it may, the Trump administration agrees with this, is trying to create more transparency over, say, prices that insurers pay to hospitals. But you know what happened when they did that? So we created a price transparency ad, and we basically said, it needs to be revealed to the public every price that's paid by from insurers that they pay to producers, like to every hospital in the United States. Well, you know what happened is they were like, okay, we don't want to do that. And when they sent the first set of documents, I kid you not, the volume of the material was so large that it could not fit on a supercomputer.
Oh my goodness.
We brought one of my colleagues here to talk about it, and she said they got this huge dump of terabytes of data that no even supercomputer could process it. Either it was in so big a file it couldn't be processed, or it was in multiple gigabyte files that added up to terabytes. So my point is that I think they kind of did that on purpose. It's kind of like lawyers going and filling a room of paper, and
Right.
then just the one piece of paper you want is right in the middle of the room in the 370th box.
Right.
That's what they were doing, is they didn't really want to tell you the transparent negotiation they were having between the producers and the insurers, which is what the government was trying to get at, is so that I could know what the price of my MRI was.
Right.
And that's really important that we know that, but it's really impossible to know it. And they've hidden it because why do they hide it? Because it's a proprietary decision. It's a
Mm.
negotiation between a seller and a buyer, and they don't want us to see it because then they're giving away all their market power.
Yeah, this idea that you mentioned the Trump administration, this idea that they're talking about you're going to give people X amount of dollars and they're going to negotiate themselves their best deal. When we know that these insurance companies, where there's economies of scale and they have the power to do that, even they have problems doing that. And there's very little transparency to us, the end user,
Right.
so-called, on that. It's
And,
just a preposterous notion.
and you can overwhelm the consumer. I'll just cite you another quick example. When we did an experiment, and I have some papers that my colleague Mary Politi and I did in the rollout of the Affordable Care Act, and she had the idea of medical decision making. Look at how people make decisions, and to figure out if they could navigate these complicated decisions. So we actually created like a tool, and we put out there like the parameters of health plans, the premium, the co-payment, the deductible, so on, all the things that are important in a health insurance plan. And you know what was one of the most mind-boggling findings that we came out of this was we asked people what they thought the definition of all those terms that I just cited to you, premium, co-payment, deductible. You know what they thought a deductible was?
What?
A reduction in the price of medical care.
Oh my God.
So, and of course, if you know what a deductible is, it's the exact opposite. It's how much you have to
Right.
pay before you
Right.
actually start paying.
Exactly.
So you
Right.
can imagine a person would go up to this Amazon like marketplace, and they go and they look at a plan. They go, "Oh, it's got a $7,000 deductible. That's great. This other one's only got $1,000 deductible. Of course, the one you want is the one that's got $1,000 deductible."
Right. Right.
So, we've created a monster where people have a hard time figuring this out, and we give them 40, 50 choices, and we think that's great. The more choices, the better. I'm not sure and there's
No.
evidence by Tom Rice that more choices is not better because people can't
No.
process that in their head that, well, that sounds like an anti-free market concept, but we want people to make the right decisions.
Right. And when I first encountered Obamacare, if you will, I was coming from uh, what came before, which was an
Yep.
absolute mess. So this was a lot better, but still, you find yourself, you have this tool to sort through, but the more you sort through and the more choices you have, even as you're drilling down, perhaps counterintuitively, it becomes more and more evident that it's all a gamble.
Oh, yeah.
You're just trying to game this stuff out. You're going through all these scenarios, and it can really give you a lot of agita, a lot of anxiety. You don't know. You'll never know if you made that right
Yeah.
decision until you find out.
And that's what when I teach about insurance in my classes, this is one of the reasons, getting back to your first question, why I like teaching health economics is insurance is weird if you think about it. I'm gambling that I lose and you're gambling that I win in a health way. I'm gambling that I get sick and that you have to pay a lot of my bills, and you as the insurer gambling that I'm not going to get sick. Because if I'm not sick, they make money. If yeah, so
Yeah,
it's a very weird gamble. It's like because in our models, we wrestle with the concept like how is it that we have people that buy health insurance at the same time that go to the casino?
right,
So they don't like risk, but they do like risk. Well, it
right.
turns out healthcare is something you don't like risk about. You don't mind like throwing the thing away at the crap table, but you don't want to gamble your life away.
Yeah, I do want to pivot to Medicaid because
Yeah.
this is really of great importance to Chestnut. But again, we could talk about this all
Yeah.
day. But it's kind of interesting because it does strike me, not to be flippant, that when we talk about healthcare economics, the further we get into it, it becomes more, becomes like a cross between Alice in Wonderland and behavioral economics.
Yeah, exactly. Hmm.
It becomes something else. It's real. And there's this other, idea that if you make healthcare too affordable or you make it too accessible, there's going to be this moral hazard. And
Hmm.
people are now going to consume it like it's a consumable item as opposed to what it fundamentally is, which is insurance in the event something happens.
Right. And again, that's a principle from, if you dive into it, from the principles of insurance, which is like in car insurance and in house insurance, there's a moral hazard. Like if I insure something, well, people become more risky. Like if I get a car accident and I go and I say, look, my you got to fix this thing that really was actually broken before the car accident ever happened. That's a moral hazard. So like you have an accident and you don't tell them that in fact you already had an accident before that and you make them pay for the one. So that's
Yeah,
moral hazard. Or
yeah,
if you have house insurance and you don't pay attention to the fire hazards in your house because you know they're going to pay for
right,
it. That's moral
right,
hazard. But the
right,
concept of moral hazard in health is kind of crazy. It's like I'm going to have a moral hazard. Well, I'm going to make myself purposely sick
right.
because I
Or
have
like all of a
insurance.
sudden I got the gold plan. Now I can do bungee jumping.
Yeah, that's right. I mean, it's like, okay, maybe people behave that way, but I don't really know very many people that behave that way.
No,
Just be
no.
they're not going bungee jumping because they have health insurance. That's not
Yeah,
what.
no, no. Again, I promise to pivot to Medicaid,
Yeah.
and we will, we will. I just want to ask you one other question before we get to that.
Yeah.
Obviously, now we're talking about the ACA subsidies. Obviously,
Yeah.
that's become a problem. How do you see that playing out?
Well, it's a really interesting example of what we've been talking about because the as the trajectories played out over time, when we say collectively when the people who wrote the Affordable Care Act created it, they created this subsidy structure, which there were flaws in it. I will be readily admit that there are some things that were flawed about it. And then the Biden administration came in and corrected some of those flaws by making the premiums more generous, especially for lower income people, because there was some reluctance of people like between 100 and 200% of poverty line to buy the plans. And it really was effective. But it was, the Republicans had never really liked the Affordable Care Act, and they don't like this aspect of it. And they have a few valid criticisms of what was done, because basically, in the way the subsidy structures put in place, all the costs are shifted to the government. And, so again, on the moral hazard side, it's the government that's bearing the risk, not the individual. So they can buy a pretty expensive plan and the government pays it all if they're low income. So we can fix all that. But the problem is that we're now on the precipice of it's almost, 2026, and people are about ready to have increases in their out-of-pocket premiums that are going well over 100%. There's some people have been documented their premiums going to go up to $27,000, which is a cost of a car, and that's a large example. There's a lot of people that are sort of in the world of going from 500 to 1,000 a month. Maybe that doesn't sound like much to a higher income person, but if you're only making 15,000, 20,000, 30,000, that's a lot of money. So there are going to be people dropping their coverage. So we're going to go backwards in the insurance. So we need, in my opinion, I would keep the subsidies in place and fix some of the flaws in the system. Don't just throw the whole thing out. And unfortunately, Congress is at such loggerheads. They may get there, but I'm not convinced they will. They're certainly not going to get there in time, which means
Yeah.
some people are going to drop their coverage.
Yeah. I mean, the whole thing is jerry-rigged. The Affordable
Yeah,
Care Act is jerry-rigged
yeah,
by its nature and by necessity. Unfortunately, you can't just blow the whole thing up and start
yeah. I mean,
anew.
it is what it is. On the right, they say, "Oh, we're giving too much money to insurance companies." Well, that's true. On the left, they're saying we're giving too much money to insurance companies. They're right too.
Sure.
So that could we figure this out so that we don't give them so much, but we also deal with not making more people uninsured. That's
Yeah.
that's what I
Yeah.
want to do.
Well, we're always 2 weeks away. It's sort of like Zeno's
Yeah.
paradox. You would keep on advancing half the way to the goal. You never
Yeah.
get there.
Yeah, they made the point that, they had this government shutdown for what was it, 80 days, and they could have come up with a plan on the time, but they
Yeah.
didn't, but
You
whatever. So
you think.
yeah,
Okay, Medicaid.
yeah,
It's often misunderstood as just a welfare program. What's the reality of its role in covering working families, the elderly, and rural populations? Of course, drawing on your research in this area, Medicaid
yeah,
expansion.
that's a great question because if you go back to its original formation, Medicare was created to help the aged get insurance, and Medicaid was created for the so-called poor. So I think that's the germination of its notion that it's a welfare program, and it's tied to categorical, what we call categorical programs like the AFDC program, now TANF, and SSI program, and so on. I'm throwing a lot of acronyms up, but let me step away from that. And the point is that basically Medicaid is a program that does cover lower income people, but over time it's morphed to cover important populations, which I think we've learned in this recent debate are very popular. So children, it now covers children to 300% of poverty. It covers the disabled. I haven't met a person who doesn't want to cover people with disabilities, both aged and non-aged people with disabilities. And it's grown over time with that. Covers pregnant women. 40 to 50% of the pregnancies in the United States are born with Medicaid funding. And so you got children, you got pregnant women, you got disabled, you got low income aged persons. And then the last piece we added in is the working poor, and that's the Affordable Care Act. 19 to 64-year-olds who could not get insurance otherwise, but their incomes are so low that they can't go out in the market and buy it. And so the determination was we need to give people Medicaid if they're below 138% of poverty, which is like $15,000 a year. So it struck a lot of people as like that was the missing piece because I don't know if people realize this, but single males, single females, and married couples were not eligible for Medicaid before the Affordable Care Act. Basically, in order to get on Medicaid, you had to be a custodial parent with a child, usually single mother, or you had to be disabled or you had to be elderly. That was it. And you couldn't
Right.
get on there if you're a single person. So the Affordable Care Act put that last piece in to protect the rest of the poor. Does that make sense?
Yeah, no, it does. What are the implications for these proposed changes to these work requirements? How do you see that playing out?
Well, I mean, that kind of follows along what I was just saying because when you look at the work requirements, so-called work requirements in the big bill, they are aimed only really at the 19 to 64-year-olds, and they're not, thank God, not aimed at children or the elderly. And there's exclusions for being a child, being disabled, or being aged. So those pieces of Medicaid are put aside. So really, we're talking about the 19 to 64-year-old working poor. And there's been a long belief among many people, mostly conservatives, but there's that's broadly stated, not just Republicans, that people should work if they can. And yeah, you can give them benefits, but if they can work, they should go to work. Well, the truth of the matter is that I've done research on this. Many people have 60 to 70% of the people on Medicaid are working in that group that I'm talking about. 60, the non-elderly, non-children, so the 19 to 64-year-olds. 60 to 70% of them are already working. So what is the problem we're trying to solve here? Of the remaining 30%, all but 10% are either disabled, caring for a small child, or in school. So when you get down to it, it's about 10% of people who don't fall into the category of either working already, disabled, caring for a child, or in school. So the whole bill is aimed at 10% of the population. And the fear that we have about this is we're putting a blunt instrument in there that's going to through, and I could get into the weeds on this, but the way that a lot of Medicaid programs work is pretty dysfunctional. So when you put in a structure to prove that a person's working, you're going to lose people through the enrollment, the process of proving that they're working. There's a lot of paperwork they have to submit. They're going to get lost in the process. They're going to so on. And that's where the big numbers come in of like 14 million people might lose their insurance. And it's mostly because of the dysfunction of the system, really. And, it's not that we're saying, there's 14 million people that are not working and sitting at home that, because really most of them are working. It's the paperwork and the bureaucracy that's going to lose them. And then we're going to be back to a lot of people that need coverage who don't have it. Does that make sense?
It does make sense, and it's a pretty terrifying prospect. I'm
Yeah.
curious your thoughts on the 50 billion Rural Health Transformation Fund. To what extent do you see that preventing the closure of rural hospitals and safety net providers?
Yeah, that's interesting because that appeared real end of the debate in the bill, the debate over the big bill as a carrot to get a few of the last votes they needed. And I'm characterizing what's widely reported. So this is not me making this up. You can look this up. There were like 3 or 4 senators who were on the fence and they needed to like be convinced to vote for it. And they had particular concerns about the effects on rural health, like my senator, Josh Hawley, Senator Murkowski, Senator Collins, who ended up voting against the bill anyway, so on. So they created this rural health transformation fund, and it's being characterized the way you have said it, which is it's an offset to the 137 billion in cuts that are going to come to rural areas. And so it's not clearly going to do anything it's not enough to offset those cuts. So that's one comment you could make. The other thing that is now the rhetoric is changing quite a bit. If you say to somebody in say HHS or whatever that this fund is designed to stop the closure of rural hospitals, they would say no. They would call it a rural health transformation fund. So I've said that out loud, like, oh, this is in part to help keep rural hospitals from closing. And they'll say, oh no, that's not what it is. It's called the Rural Health Transformation Fund. And they will say directly that the dollars are not going to go to hospitals. And there's a fight going on as we speak, and I'm sure it'll go on for quite a while to make sure that all this money doesn't go to hospitals, which is going to be interesting to watch. So,
Yeah.
yeah, because the hospitals are the big gorilla in the room, and they do want most of this money. But I will say, as a rural health researcher, that we have a lot of other parts of the system that need repair. Mental health and primary care, FQHCs, and so on. So you know, even though I will argue that the rural hospitals are really going to be harmed by the big bill, it also would be the case that we need some help in the other areas. Does that make sense?
Yeah. Yeah, it does. In fact, you again anticipated my next question, how do safety net providers like FQHCs and community mental health agencies prepare for this work requirement rule?
Yeah, so that's great. Yes. Um, they uh, they are thinking about it and preparing for it. As I mentioned earlier, we anticipate, or the estimates are, and nobody knows for sure, but it's maybe up to 14 million people are going to lose their coverage. So now we're going to be back in a situation where the safety net providers, the community health agencies, the FQHCs are going to go back to a world where a significant percentage of their population is going to be without coverage. And, I've seen the data, a lot of these providers, at least in like FQHCs, they had probably 25, 30% or more of their population who was uncompensated care that they never expected to get a dime out of them. And the Affordable Care Act, the Medicaid expansion in the states that did this closed that gap. So they at least were getting something to cover many of those people, not all of them, but many of them. And this will turn it around, and they're really nervous. They're really nervous about what's going to happen. And it's going to lead to, there'll be closures of some smaller, NGOs, and FQHCs are going to really have to cut back, or, we're all worried about this.
Yeah, you mentioned Senator Hawley. Obviously, he's been outspoken and concerned about the negative impacts on his constituents across Missouri. But, I don't know to what extent he can do anything, regardless of how vocal he is. And at some point, others are going to have to come around because they're going to see it in their states. It's not going to be something that you're going to be able to keep from view. I mean, people are going to be able, it's going to be a very visible crisis, I believe.
Yeah, he clearly, the credit I will give to him is that he's reading the tea leaves properly. And I think he realizes some important facts, that there are more rural people on Medicaid than there are urban. There are more people that, and there's in the state of Missouri, that the Medicaid expansion had an important effect. The marketplaces had an important effect. And if you reverse some of these things that we've already talked about, it's really going to harm the hospitals and the safety net providers in Missouri. He gets all that. He's been told that. And he articulated it in a New York Times editorial. So we were like, wow, okay. So he pushed back on a lot of the harsher elements that they were thinking about in the big bill, but yet he voted for it in the end. So
Right.
it was interesting, but almost like the next day he said, well, I didn't really like it all, but I voted for it anyways, and maybe we can reverse some of the parts that I don't like. And, it was like, and so he was, I mean, what he's saying there is, and this is important to say out loud, most of the provisions of the big bill don't go into effect until 2027.
Right.
So and he quite clearly said, we have time to, if there's things that are really going to be harmful, we can reverse it. And, he's clearly, I think he's playing the long game. He's aiming, I'm being a little bit amateur political scientist here. I think he's going for the populist wing of the MAGA movement, that there's a whole wing of the populist of the Trump coalition that's really not conservative Republicans like you and I knew this when we were younger. These are populists. These are, low income rural people, low income urban people that feel harmed by the economy we live in. And he feels like he has an opportunity to speak to them. And, those are a lot of the people that have been helped by things like Medicaid expansion. And he's not dumb into saying let's not kill that because they're going to be mad at us.
Yeah.
And so it'd be worth watching if it was, personally, I think it was surprising, maybe disappointing that he voted for the bill after saying he was, against many of its provisions. I will say that I think the tea leaves I heard was he worked to soften some of the worst aspects of it. So I gave him that credit. I think that if the bill was worse than it actually ended up being, he might not have voted for it. But be that as it may, he voted for it. And he's kind of signaling, oh, yeah, we'll change it. So what'll happen after 2026 is going to be worth watching because
Yeah,
there
I
may
do.
be a different Congress and by then. So,
Well, it very well could be, but I think you're also seeing first indications of a real schism between
yes.
MAGA and America First. Where
Hmm.
America First is more classically populist, whereas MAGA is MAGA. And you're
Yep.
seeing that with Marjorie Taylor Greene, who's talking about affordability. No, it's not a hoax, because these are things that, again, they're in plain sight.
Yep.
It's happening with HUD, and this bill is coming down thud. It's in plain sight. Grocery prices, energy, it's all in plain sight. So at some point, the likes of Holly maybe actually maybe backing a winning horse.
Yeah,
So
you make an interesting point about Marjorie Taylor Greene because she's another example of this because she's been citing like one of her main reasons was my son was going to be harmed by these marketplace subsidies going away. So, and so they kind of get that this is like a real thing. The affordability thing is a real thing. And I think they're smart about this. I don't know if people know this, but Holly's always had ambitions to run for president. So
yeah, oh, for
I
sure.
think, yeah, I think this is what this is about as well. So
Yeah, no, yeah, I think what didn't he throw his hat in the ring the last cycle, if I'm not
I'm not
mistaken?
sure if he ran, I don't know if he did the last cycle directly, but he toyed with the idea. He's always been waiting until Trump moved on.
Yeah, no, I don't think that's a
Yeah,
well-kept secret. I think it's pretty
yeah,
clear that
yeah.
he's been making noises in that direction and positioning himself. Last question, and we did gallop through this, and
Yeah, I don't know how we did it. We got through all
we
your questions.
yeah, no, I really appreciate. I thought I was going to have to turn the last three or four into a lightning round, so thank
Yeah.
you. And I don't know how we lightning round some of these questions. Last question, and you sort of touched on this a little bit, but in the unlikely event you were called on to advise the Trump administration on healthcare reform, what evidence-based changes, based on your work in health reform, would you prioritize to address the uninsured rates?
Yeah, well, it's a great question. It makes me it would be fun if they listened. But it's like but frankly, some of the things I'll cite here should be bipartisan. Because I will say, we touched on this earlier. Like one thing I would say, and this is getting into a little bit of the weeds, so I'll try to keep it at a helicopter level. But basically, if you read some of the writing that I've done, I would do things that recognize the complexity of the markets. And that if I think it's fine to put in place a market structure of having competing healthcare plans, but recognize that there are market issues, particularly in rural America, that make it difficult for that to work. So the one thing I'll cite is, you know, for a market to work, you have to have enough people in the market for it to work. And we've written about this, my colleague Abby Barker and I, and it's called Economies of Scale. For insurance to work, you have to have enough people. So you can sell insurance pretty easily in St. Louis or Chicago or Miami or Los Angeles, but it's really hard to sell it in rural America because when you have more cows than people, you're not going to be able to sell insurance there very easily because you can't spread the risk.
But
So
not, isn't it just, it's not just more people, but it's people across the spectrum of
yes,
health, good health,
right.
not so good health, etc.
Yeah, and right, and so you have to recognize that a lot of rural people are chronically ill and they're older. And so if you can recognize this and not sort of do what's sort of the simple thing to do, which is set up markets based on, say, simple political boundaries like counties or states, but be a little bit more creative. Like I'll cite a wild example. My colleague Keith Mueller and I, when they created the Medicare Part D program, we suggested they create a market that went all the way from Minnesota to Montana because we said that you won't get enough people to make it work in any one of those states. And they agreed with us, and Blue Cross got really furious because their legal structure is state-based. But the federal government agreed with us. So if you look, one of the markets is goes all the way across the northern part of the country, picking up the fact that North and South Dakota and parts of Minnesota and Montana are so sparsely populated. We basically believe that you needed at least 5,000 people to make a viable product. And, they bought that argument. So that would be one that, just sort of recognize those sort of market failures we talked about earlier. I think, and I would also sort of throw in the bucket of those things we talked about, transparency. One other sort of wild idea that, I think is sort of out of the box, but we talked a lot about rural health. I think that, we do a lot of gerrymandering around rural health in the United States. We create a lot of special payment programs and so on. I would love it, and several of my colleagues would love it if we just recognize that rural health and maybe some other things are what I would call a public good. That it's really important, and in a public good in the economic senses, it's important that the government help provide this because the market won't, and that providing it provides benefits to everybody. So I think if we just recognize that we cannot live in a society where you have rural people that don't have access to healthcare and that are going to die because of it. So they don't have access to OB coverage, and they can't have a baby near them, and they can't have a nursing home near them. And then it might be just worth putting some dollars to make that be the case. And that if you just call it a public good, we treat schools as a public good, we treat fire departments and police departments, parks, those are public goods. So why not, healthcare for the, rural health and maybe other populations? Just sort of say, we just as a society think we should put a pile of money behind making sure that everybody has access to basic services. So
Yeah.
those are two of ideas at least, but and then I think we could help deal with some of the uninsured problems that we're talking about. And then simplify these markets as we talked about these. I think the Affordable Care Act has helped a lot of us, helped, frankly, a lot. We've cut the insurance rate, uninsurance rate in half. What could we do to make it better? Simplify how people buy insurance. Deal, frankly, with some of the excesses of the insurance companies because they're making a pile of money off of this. So
They are.
I think we could actually do things to actually, and I think that's a fair criticism that's coming from the right on this, is that we're sending a lot of money to insurance company. I chaired the Medicaid Oversight Committee, and I always said this, that they just sort of do what the insurance companies want them to do because they're a pretty powerful lobby. But I think we should be questioning at the edges. The Affordable Care Act did a lot with that. It limits the part that goes for the benefit, not for the benefits, to 15% of the premium. But I think we need to be questioning some more of what they're getting.
Yeah.
So
This
those
is
would be three
just,
things that I would,
yeah. Hey, from your lips,
yeah. Do you disagree? Does those make sense? Yeah.
No, they all make sense. It's just so frustrating because healthcare is such a large, complex, and incredibly frustrating topic because, as we've discussed, there are so many parts, so many components. You have the insurance marketplaces, you have providers, and then you have all these dazzling technologies and innovations and breakthroughs, right? And they all seem to exist in their own little silos. You hear about these
Yep.
breakthroughs, but it's like, yes, but it's inaccessible. It's like, so many of us are pressing our nose up against Tiffany's window, and oh, look at all these incredible baubles, these powerful new
Yep.
technologies, but we can't get there. We can't get there because we're grappling with all this nonsense and we can't figure a way forward. We can't compromise. It's incredibly frustrating.
Yeah, I think we talked about this when we had our pre-call that health economists, if you ask them what's the driving force behind healthcare costs in the United States, and we have the most expensive healthcare system in the world by far. We took off Canada and us were about the same in 1970, and now we're like way ahead of them in terms of percent of GDP. economists would say the driving force is not what's often listed, which is high prices of doctors and high prices of hospitals and insurance companies and government intervention and aging of the population. Those are all important factors. Most important one is technology, the one you just listed. We, the healthcare sector is remarkable in the United States because we literally we can save people that we never thought we'd be able to save in terms of cancer and many things. And that's remarkable, but the price is out of control. So if you think about it, the fundamental disconnect we have is we're almost the last remaining private healthcare system in the world. Most other systems in the world are public financed, which means that they heavily regulate the healthcare sector. We do not, despite what you hear, we do not regulate the healthcare sector that much. We now are getting to the point where almost 50% of the dollars comes from Medicare and Medicaid. 50%. So
Wow.
we're a private system, so that it's interesting. The decisions are made privately by hospitals, private healthcare systems, private doctors, private insurers. So we have kind of made this weird decision that said, oh yeah, do whatever you want, we'll pay the bill. And it's like, so we got almost the worst of all worlds. And when people ask me like, well, what happens in Europe and other countries? Well, they don't do that. They would never let the drug companies charge the prices they do, or the hospitals charge the prices they do. They would regulate them because they say, we're paying the bill. We're going to tell you what we're going to pay you. And that's a
Well,
kind of an anathema to the United States, but be that as it may.
yeah. Tim, I really do appreciate this. I know you were kind of pressed for time, so you probably went over a little bit than you otherwise would have allotted. So thank you very much. Really do appreciate it.
You're welcome, and I appreciate the having somebody ask great questions and be willing to hear it. So
Oh, thanks so much. Today I spoke with Dr. Timothy McBride, currently the Bernard Becker Professor in the School of Public Health at Washington University in St. Louis. This is Charles Epstein for the Catalyst Podcast. Thanks for listening.